My name is Rachel Vetter, and I am a third-year medical student at the University of Nebraska Medical Center, and I will be presenting a major complication of pink eye. So a 32-year-old male with no significant past medical history presented to the emergency department with 2 days of a rapidly progressive pruritic rash, odynophagia, and a cough. He had previously received treatment for bilateral conjunctivitis 1 week prior to his presentation without improvement of symptoms. The patient noted that he works as a tree trimmer, but denied any recent exposure to tall grasses or vegetation. He reported that he went fishing 2 weeks prior and used chicken liver as bait and may have contaminated his eye at this time. He denied any prior history of genital ulcers or STDs, as well as a history of tobacco or IV drug use. He reported social alcohol use and lives at home with 3 dogs and a cat. On initial presentation, the patient had a pruritic and painful vesicular rash that was distributed over his bilateral upper extremities, lateral torso, and bilateral feet, ankles, and lower legs in a photodistributive pattern. He had a few blanching macular lesions on his bilateral palms and soles, as well as ulceration and sloughing of the labial mucosa. He also had 2+ bilateral keratoconjunctivitis and scleral injection. Vitals on presentation included a temperature of 37.8 degrees Celsius, blood pressure 121/58, heart rate 75, respiratory rate 16, and 98% oxygen saturation on room air. A CBC and CMET were within normal limits, and an HIV antigen and antibody panel was non-reactive. The patient was admitted to the hospital at this time. It was suspected that the new rash development was due to disseminated HSV, and acyclovir was started empirically. Over the next few days to a week, the patient developed plaque-like lesions on the hard palate and progressive mucosal sloughing that made it difficult to tolerate oral intake. Over this time period, the rash became less vesicular and developed a target-like appearance. At this point, Erythema Multiforme was suspected and azithromycin was started for empiric treatment of mycoplasma. I have a few slides that show the progression of the patient's rash during his admission. Pictured here is his right arm and back with the target-like lesions. Over the course of a few days, the lesions began to flatten, with some developing a bolus-like appearance, with the skin eventually sloughing off. The rash progressed in a similar manner on his bilateral lower legs. The mucosal involvement of the rash worsened throughout his stay, with day 8 involving an estimated 90% of the oral mucosa. Lesions on his bilateral palms and soles developed the targetoid appearance as well. The patient also had progressive bilateral upper and lower eyelid erythema and edema during this time, but is not pictured. It should also be noted that the patient's bilateral conjunctivitis gradually resolved over the course of the week. An extensive infectious workup was performed and was significant for positive Mycoplasma pneumoniae IgG and IgM antibody titers. Type 1 and Type 2 HSV IgG was positive, and a respiratory pathogen panel was found to be positive for adenovirus as well. It was determined that the patient's diagnosis was likely adenovirus and mycoplasma-related erythema multiforme major. During the patient's admission, he completed courses of acyclovir and azithromycin and was started on topical and systemic steroids. The patient also received IV fluids due to severe odynophagia that impaired oral intake and hydration. After 5 further days of supportive treatment, the patient was discharged from the hospital with recommended follow-up with his primary care provider as well as dermatology. Erythema multiforme is caused by a cell-mediated immune response, and the term erythema multiforme major is used to describe erythema multiforme with severe mucosal involvement, such as in this case. Infections are associated with 90% of cases, with HSV-1 being the most identified etiology. Mycoplasma pneumoniae is the second most common etiology, especially in children. Medications have been known to cause less than 10% of cases. Our patient had negative serologies for recent HSV infection. Erythema multiforme major, secondary to adenovirus, although rare, has been documented in the literature, with an initial presentation of keratoconjunctivitis similar to this patient's presentation. Erythema multiforme can often be difficult to differentiate from Stevens-Johnson syndrome and toxic epidermal necrolysis, as they share many characteristics. The diagnosis is largely clinical. Histopathology is insufficient for differentiating the two, as both involve cytotoxic lymphocyte responses against altered keratinocytes. As previously mentioned, infections are the most common etiology of erythema multiforme, while SJS-TEN is most commonly due to medications. Erythema multiforme presents as round erythematous papules, followed by the development of targetoid lesions. The lesions in SJS-TEN have a macular appearance with the formation of bullae or vesicles and may cause full-thickness epidermal necrosis and sloughing. The lesions of EM are more commonly found on the face and extremities, while SJS-TEN lesions are more likely to involve the face and trunk. Mucosal involvement is less common in erythema multiforme as well. SJS and TEN are more likely to present with prodromal fever, fatigue, and flu-like symptoms. Treatment for both includes supportive therapy, plus discontinuing the offending drug if necessary for SJS-TEN. Altogether, it is important to distinguish EMM from other dermatoses that may present similarly, as it can help determine if the underlying etiology is more likely infectious versus drug-induced and can influence the workup and treatment strategy for the patient. Recognition of erythema multiforme major and identification of inciting factors can present a diagnostic challenge in patients with atypical presentations, such as this patient who initially presented with bilateral keratoconjunctivitis. Therefore, erythema multiforme major with prodromal conjunctivitis should prompt suspicion for adenovirus infection. Early diagnosis and identification of the triggering pathogen or pathogens allows for more rapid support and treatment, providing better patient care overall. Thank you for listening.